is Keith is going to show us how to preoperatively plan for an intertrochanteric osteotomy for a femoral neck nonunion. He's going to do it very generically, not with software. So at this point, I'd like to turn it over to Keith to come on and take us through the next portion.
Good morning, all. I want to thank you all for joining us, and particularly thank Mike and Brett for sort of turning the Corona disaster into an online course, which I hope will be as good or better than a 3-day in-person course. So what I want to do is go through a generic planning sequence for the proximal femur. And so we want to be able to get from your x-ray on your left to the right in a reproducible fashion. And the objectives are to have a standardized technique for planning a coronal plane correction of a deformity, either a mal or non-union of the proximal femur. This is based on the plane radiographs with some caveats, which we'll go over in a minute. And hopefully the workflow that we do here, basically in old school paper cutouts, will be transposable to most of the digital platforms. I don't have extensive experience with anything except for OrthoView, but it worked well with that. And I'm sure that with the experience you'll get with BoneSetter, you'll be familiar with that as well. The assumptions we're going to use is that most long bone mal or non-unions can be reduced to a single-sided deformity. And that'll give you two separate components which you can rearrange to correct your deformity. And that in most cases, there are multiple configurations that are possible. And probably the least well accepted of the assumptions is that despite the fact that it's 50 years old, that the angled offset blade plate at either 100, 110, 120, or 130 is the ideal implant for deformity correction in the proximal femur. And the restrictions with that, which you all need to be aware of, is that there's only a 4-hole side plate, and the width of the blade is 14 millimeters. And so if you're planning from a frontal perspective, the first thing you do before you go to the frontal plane is to make sure your blade is going to safely fit within that corridor and hopefully follow the native version of the neck. So what do you need? You need AP and lateral views of the proximal femur and also the distal segments. And those technically should be separate x-rays. So we spent a lot of time harping on how to get perfect x-rays. Well, for this exercise, the classic preoperative normal planning x-ray would be a torsion compensated perfect AP of the proximal femur, which would mean that you'd know in advance what the torsion was, and if it was 15 degrees of anteversion, then you would internally rotate the proximal femur 15 degrees to give you a perfect AP. And so there's a general correlation between increasing neck shaft angles and anteversion. And so the steeper the neck shaft angle, the more cautious you have to be about the error introduced by not having a torsion compensated AP of the proximal femur. And then you have to decide whether or not you actually need that study, whether it's CT based or MR. We have, and many times in the past, used MR. I would probably discourage that use because of the amount of time in the scanner. The chance for a position change somewhere between the proximal and distal cuts is too high, so stay with CT torsional studies. So this is what my platform looks like. I still use known magnification printed views of the deformities and then transferred to vellum overlays. And that's what you're going to be looking at as we go forward. So here's our patient. She was I think she was 64-year-old race walker who complained of knee pain for about 6 weeks before she completed her femoral neck stress fracture. And this was her initial film on the left. And you can see there are already some problems with this. And you would look at the neck mismatch relative to the intertrochanteric line. You'd say, well, probably in addition to some potential problems in the frontal plane, that may very well be a rotational deformity of this femoral neck. At any rate, she went on at 8 months to this position, painful, disabled, and extremely unhappy. And so now we have to have a way of reproducibly getting to a successful plan for this patient. Where do we start? We got to start with Powell's, this article from 1935, which was basically the femoral neck fracture, a mechanical problem. And he was the first person to actually look at routine ways of managing these frequently neglected femoral neck fractures. And so unlike us, where almost all of them have been fixed and then failed, most of his were basically deformities that had occurred and then secondarily displaced with severe deformities. And if you look at the way they were originally fixed, it was with a tension band. So the tension band fixation was all that he had. And that probably gave an undue emphasis to the so-called Powell's angle. I'm not going to spend much time on that because I think it's probably far less important now than it was originally. And so if we looked at the correction guidelines, originally, this is the numbers given by Litton in its original manuscript, is that if you wanted to create compression across the non-union site, you had to bring the non-union site to within 20 degrees of the horizontal axis, which resulted in a lot of stick femurs and a lot of very severe corrections. And so then the question is, how much deformity can you accept in order to get enough compression? And the answer is far less than we probably would expect from looking at the literature historically. And so if you look at some of the series, especially those in which a hip screw is used for the correction, we have very high CCD angles. Well, what is the normal CCD angle? It's the average is around 127 degrees. The normal quoted range is 120 to 140. Most of the most accurate studies show that the right is slightly higher than the left for reasons which are unclear. And these are all based on skeletal direct measurements, so they're more accurate than the radiographic studies. And despite a lot of our misconceptions to the contrary, male and female neck shaft angles are approximately equal, although there are certainly within racial populations small differences. Another thing that people worry about and are talk about is that if you take a normal, and this is not particularly a great depiction of a normal on your left, a normal mechanical axis going through the center of the knee from the center of the hip to the center of the ankle, and then you do an abduction or valgus osteotomy, then that obligates a lateral mechanical axis shift. And the same is true if you go into varus. And so theoretically, the compensations for those would be a lateral shaft displacement for abduction and a medial shaft displacement for adduction or varus. But remember, those considerations are not operating here because we're going from abnormal back to normal. So using shaft displacement to compensate for a theoretical problem at the knee, I think is something we want to just dispel as an important concept. It really has no place here because we're going back to relatively normal CCD angles. And what we want at the end is a proximal femur which looks very close to normal. And that is because we can stabilize it with a robust device like an angled blade plate. And we don't want to leave residual deformity of significance for the potential next operation. So step one is our normal X-ray, again, rotationally compensated. You can, and then we're going to basically reverse that for our normal template, and we'll come up with a CCD angle or neck shaft angle of roughly 135 degrees. And then our next measurement will be from the deformed side. And this gives us 110 with a difference of about 25 degrees. So that makes it difficult because none of our blades are at 5-degree increments, and the easiest osteotomy to set up is one in which the blade insertion is orthogonal to the longitudinal axis of the femur. And so I arbitrarily, in situations like this, will usually default to the next size higher angle. So slightly more valgus is acceptable. A lot more valgus is not. So 25 degrees difference. And now we're going to do an overlay. And on the overlay, we're going to line up primarily the lesser trochanters because that's normal anatomy. And then we'll look at, sequentially, we're going to look at our funnel plane correction, which is roughly 25 degrees transposed to 30. We're going to look at leg length discrepancy, which should correlate with what we've measured clinically. And then we're going to look at offset. Well, we don't have a lot of ways to compensate for offset. And in general, frontal plane corrections will have a offset implication. So if you go from varus to valgus, you're going to lose offset. And in extreme cases are things that you can do to compensate for that. For the most part, we just want to be aware of what we're going to do and how it impacts offset. And so at the end, you have, excuse me, all of these variables on a summation view. So frontal plane correction, leg length discrepancy, and offset. And then we're going to do a preliminary assessment of what our osteotomy options are. If you're going to do a 30-degree closing wedge, you can put it anywhere you want. But once again, you have to do it in a way that's going to be easiest for you to execute. So that's one closing wedge, full thickness. This is a much easier one in which you have one transverse component. The other nice thing about a transverse component is that if you have a horizontal plane correction, and usually that is brought about by residual retroversion of the neck following the original reduction of the femoral neck. It's very difficult to compensate at the neck level, so what you do is end up compensating by an internal rotation of the distal segment. And in order to do that, the easiest way to do it would be you would have a horizontal plane reference proximally and distally. You would do a transverse cut. You would internally rotate by the desired amount and then do your closing wedge. That is perfectly set up by a transverse osteotomy, whereas an oblique osteotomy in two segments makes it much more difficult. The easiest way to plan it is to have two segments. So if we go back to our transverse intertrochanteric osteotomy, then we have a proximal segment and a distal segment. And then we have a goniometer based, digital or otherwise, opening wedge. And then we can go to a variety, essentially an infinite variety of different options. So in kids, if you really need a lot of length, you can do a pure opening wedge, but it's unstable and you can get away with it in kids, but usually not advisable in adults. You can do a combined lateral closing, medial opening in which you transpose the graft medially if you want to, or you can do a pure closing wedge, which is the most stable, the highest or the fastest healing rate, but gives you the least ability to compensate for a short leg. And then once you've gotten to whatever construct we're going to use in this situation, it was a pure closing wedge, then you're going to have a construct which will give you essentially a normal or relatively normal proximal femur in which you will then overlie whatever implant fits best. So in the beginning, if I thought I was going to do an abduction or valgus osteotomy 30 degrees, the default implant would have been a 120 because 120 minus 90 is 30 degrees. But I don't know that for sure until I see how that implant's going to fit on the reconstructed composite. So once I have the blade fit to this, and I know that my side plate's going to be long enough and that the configuration of the osteotomy isn't going to encroach on the side plate as a final check, then what I'm going to do is take that construct and then overlay the proximal segment and transfer the seating chisel to the original deformity drawing. So that gives us where the seating chisel will go in the proximal segment. Now you can try to do this at the beginning, but in general, I think you're much better off doing it after you've seen where the blade is going to fit most appropriately. And then you're going to go through an entire surgical sequence in which you're going to have a reference orthogonal K-wire perpendicular to the long axis. You want to know where the tip of the trochanter is, which requires usually a second soft tissue K-wire. You want to measure the distance between that reference and the distalmost portion of the blade channel. You want to know the distance between the blade channel and your osteotomy, and you'd like to keep at least 15 millimeters of lateral cortex in place for reasons which we'll go over in a bit. And once you have all of these things measured out, then you're going to basically figure out where you're going to do your distal closing wedge component. And you can use this another Kirschner wire if you want. I would encourage you to use K-wires to cut on until you're really comfortable doing them freehand. And so then at this point, you'll have all these measurements transferred to your drawing. And then you'll have a composite which has the implant in place, the original deformity drawing, and you should be able to take your composite. And the way to get compression is by mismatch. Okay, so hopefully most of you are used to using the articulated tensioning device to tension low angled blade plates. Low angles are 90 or 95. You can probably even tension a 100-degree plate, but the higher the angle, the more you tension a plate with an articulated outrigger, the more likely you are to at least theoretically pull the blade out of the proximal segment. So the tensioning is important in this construct, and that's based on a mismatch in which you have distal contact with a gap between the proximal portion of the side plate and the proximal portion of the diaphysis. And then if you have good bone, you can generate a tremendous amount of compression across the osteotomy site in this position. A few caveats about that technique. If you have a very long blade, an 80 millimeter blade, and you have a lot of displacement. Let's go back here. You have a lot of displacement here, and you have really good bone. As you pull this in, two things can happen. One is you're going to lateralize the shaft, so you haven't planned very well about how far you're going to seat this. And secondarily, what you can end up doing is actually the plate will bend and you'll lose correction in the frontal plane. That only happens in situations in which you have a tremendous advantage mechanically with this proximal screw and good bone. And then lastly, you should be able to take your preoperative plan and superimpose it on your postoperative drawing, and it should be identical. All right, so that's a generic plan for you with a normal template. And I'm going to just briefly touch on an alternate plan. Should mention that if you're planning for every eventuality, this was also planned for a primary total hip in case I had difficulty getting the screws out. So if you only want to have one intervention and the age group is appropriate, then you have to provide a prosthetic alternative as well. You won't always have a good normal side to plan to. All right, so this is a complicated case. This is a guy that had multiple embolic strokes. He had a femoral neck fracture on the right, which had been fixed with, or had been managed initially with a bipolar, which dislocated, had been revised. And then he had another fall and the femoral neck fracture on the left. And they said, well, leave him alone. He should be able to at least do transfers. Well, he wasn't able to transfer. And so he ultimately came to us without a normal side as a template. We don't know what his leg lengths are because he has a flexion contracture of his right hip, maybe even of his left. And so now we're going to plan to axis. And so what we're going to do, take that, instead of using a normal, we're going to correct back to a CCD angle of X. Usually 130 would be a good place to go. And so that's what the planning would then be, going back to a correction to a roughly average CCD, a normal anatomic axis. You can see how thin his cortices were, so there were some additional issues with this in terms of fixation, but that was the final correction, okay? So most of the time we have a normal, but sometimes we'll have to use local anatomic averages as a plan. So in summary, we should have two options, usually a normal side template, and the alternative is an anatomic axis correction. You can select the site based on the original plan and the osteotomy type, correcting for the deformity, which is typically varus or adduction, shortening, offset, and within reasons, and then rotation. And the goal here is to have a proximal femur at the end, which looks very close to normal, that if it fails, somebody can put a normal femoral component in downstream. And so after you've got that, then you assemble the correction, fit the implants, and then you transfer the final construct back to your original deformity drawing with the blade, and then go through a narrative, which I haven't shown you, but we'll go through next, which is usually a separate page narrative written of each successive steps, which you normally put up in the operating room in a place where everybody can see it, so everybody's on the same page.